We are going to move on to our next evidence-based medicine discussion. We are going to talk about invasive versus non-invasive approach for resuscitation. To start us off, we are going to discuss an invasive resuscitation approach with Dr. Tiran. He is ultrasound faculty at Perlman School of Medicine. He's also the associate director at the Center for Resuscitation Science at the University of Pennsylvania, where he is currently leads the resuscitative TEE program. Dr. Tiran, we're really happy to have you, and I'd like to hear your take on this topic.
Thank you very much for that introduction, Froso, and thank you to the entire committee for the invitation. This is a special day and a true honor for me. I was one of the first fellows of this very successful program, so it really fills me with pride to see how our mentors and the heads and leaders of NYC have continued this tradition in advancing this this program that is mentoring and teaching so many. I'm Felipe Tiran. I'm interested in resuscitation and how we can improve cardiac arrest outcomes. Rather than convincing you of one particular approach, what I would like to do here is to share with you my perspective. My perspective is a product of my clinical experience, of course, in an academic tertiary center, my research in this area, and the study of this field. While the quote unquote side of this debate that I got assigned in this case was to advocate for the rationale and evidence of an invasive approach in cardiac arrest, I usually don't really believe that that is the right way of thinking about arrest care in general. Yes, I do more often use invasive tools during my cardiac arrest management, including hemodynamic monitoring, TE, among other tools. But I think this is to great extent basically determined by a selection of the type of patients that we care for and the type of environment that I work at. So rather than aiming to convince you that my way is the right way, I want to give you a framework. And it is important to start by giving you my disclosures, which are relevant to this presentation. And instead of invasive or non-invasive approach, as I said, I think the question we really need to ask ourselves is, what does a patient need? What does a patient need? Well, I think this is pretty simple. The patient needs to survive. They need to be brought to life, to be resuscitated. They don't care about what tools you use. They need to have their heart return to spontaneous circulation, ROSC, ideally with a functional brain. How do we do that? As emergency physicians working in ERs, we are advanced cardiac life support. This is our playbook, our guide. But here's the first problem. The ACLS guidelines, we need to understand that they are just that, a framework, a guidebook. Resuscitation guidelines are meant to define a minimum standard of practice, but they don't really define what should be done. Unfortunately, while having a major impact in the quality of resuscitations across the board, likely responsible, I think, for the sustained improvement in impact that we saw for the first decade of the century in cardiac arrest outcomes. The guidelines have been really provider-centric as opposed to patient-centric. They have prioritized the interventions that are most convenient for us, the low-hanging fruit, so to speak. We approach every patient with the same algorithm, regardless of their physiology and regardless of their response or lack thereof to our therapies. We give them high quality CPR, we give them epinephrine and shocks when indicated. And we hope that somehow that will work. Thankfully, in the latest resuscitation guidelines that were just published this week, actually, the committee recognized in one of their key 10 home points that recognition that all cardiac arrest events are not identical is critical for optimal patient outcome, and specialized management is necessary for many conditions. I think this is a great step in the right direction towards resuscitation that is really patient-centered and not provider-centered, where we do what individual patients need rather than blindly applying one bundle for everybody. Having established this idea, I want to give you 3 key concepts to consider here. Concept number 1 is that easier is not always better. Cardiac arrest resuscitation is difficult. We need to practice and be experts at it. The fact that some of the interventions that we discuss around resuscitations are technically and logistically challenging or they are invasive, quote unquote, should not really be an argument against if they provide valuable information that can help our patients. Cannulating someone coronary is invasive and difficult and requires practice, but cardiologists do it all the time. And we don't just give them thrombolytics to MIs because it's challenging to do angiographies. Same with ECMO. In some centers, we are able to put a patient on ECMO during cardiac arrest because we know it's a life-saving bridge, as demonstrated by numerous studies. ECPR is invasive. It's not easy. It's difficult. It requires practice. It requires teamwork. But guess what? Sometimes it's the right thing and can make a difference between life and death. Concept number 2, we are the highest level of care for resuscitation. We can't really expect to provide the same level of care everywhere. It makes no sense to me that to think that we should manage patients in cardiac arrest the same way, regardless of our environment. Pre-hospital, ED, ICU, OR, the bar cannot be same for you, an ER doc running a code in the ED, than a paramedic running a code on the street or a healthcare provider running it in a nursing home. If the patient codes in the emergency department, we should be able to provide the highest level of care, to provide patient-centered and goal-directed resuscitation. Concept number 3, based on the available evidence, physiologic monitoring is recommended by our society guidelines. Guidelines that are endorsed by ACEP and Society of Critical Care Medicine, for instance, advocate since 2013 for an approach that includes the use of real-time monitoring in physiologic parameters during resuscitation in advanced settings like ED or ICU. And the reality is that not much has really changed in the way we resuscitate patients over the last 60 years. In fact, very little has changed. But while the way we resuscitate patients hasn't really changed, specifically our sort of one outcome improving therapy, closed chest CPR, we have really learned a fair amount of hemodynamics in resuscitation, and we can't just ignore this. We have learned that the key to obtain ROSC is to generate certain threshold of coronary perfusion pressure, or CPP, which is the most important determinant of chances of getting ROSC. This coronary perfusion pressure is what we can obtain with our invasive arterial line during cardiac arrest. And we do by subtracting the CVP from our diastolic blood pressure. And if we don't have a CVP, we can just use as a general approximate surrogate our diastolic blood pressure. Specifically, the studies led by Norman Pardes in the 90s taught us that we needed to generate a CPP of 15. And unless we do that, it's essentially impossible to get ROSC. So the ultimate goal is to achieve ROSC while perfusing the brain and the heart. All interventions that we do during resuscitation are directed to increase the chances of ROSC and neurological outcomes. And like Dr. Harry Weil said 20 years ago, running a resuscitation without knowing such physiology data is just like flying an airplane without an altimeter. Furthermore, there's been newer animal and human data that supports the physiology-guided therapy or strategy that uses individuals' patient physiology to guide resuscitation is better for outcomes. The summary table shows the described parameters, the parameters that we have to measure the effectiveness, if you will, of our resuscitation. On the top left, we have the most direct physiologic parameters that are available. Those are CPP and its surrogate, as I mentioned, the diastolic blood pressure. Coronary perfusion pressure and arterial and diastolic arterial blood pressure are the closest surrogate we have. The data has shown that both of these markers, CPP and diastolic blood pressure, are associated with improved chances of ROSC and survival outcomes. So yes, putting an arterial line during cardiac arrest and using that waveform to guide the resuscitation, aiming for a diastolic pressure target greater than 25 to 30 is an ideal indicator of our resuscitation performance. Entitled CO2 waveform choreography is a reasonable non-invasive alternative, but as a measure of pulmonary flow rather than an actual cardiac output, entitled CO2 is subject to many confounders that make it significantly less reliable than hemodynamic endpoints. So hemodynamic monitoring is preferred. And what do you guidelines say? What do our guidelines say? If you have an outline and CPP available, shoot for a goal of CPP greater than 20. If you only have an outline in place, use a diastolic blood pressure greater than 25 to 30. But that is not all we've learned. We've also learned that standard guideline-directed CPR just doesn't work very well. It's not very efficient. We know that when we do high-quality CPR, we're really only generating 20 to 30% of cardiac output. And we've learned that an important factor that may very well explain why CPR is so ineffective is that a number of cardiology and clinical studies over the last 2 decades have shown us that compressing at the internipple line, as recommended by guidelines, just doesn't work for all patients. That in many patients, you're not actually compressing the left ventricle, but instead obstructing the left ventricular outflow tract or the aortic root. And it's for this reason that TE has emerged as a well-suited physiologic indicator of CPR effectiveness. As you see in this image, the key advantage of TE is that we can visualize the heart in real time doing chest compressions. And as you would expect, just like transthoracic, we can use TE also to identify those reversible pathologies. We can use it to assess the effectiveness of our interventions. And as I mentioned, we can also improve the quality of chest compressions. This is an example to prove the first point. This patient had PA arrest and was getting high quality CPR. This was the diagnosis made within the first minute of resuscitation in TE. If we don't deal with this thrombus in the right atrium leading to a massive PE, this patient is not going to achieve ROSC. How do we do TE guided CPR? What makes TE unique is that we can obtain a plane in which we have a picture of the same vector, the same plane in which we are compressing the heart. So we can analyze compression and decompression phase and look at whether the aortic valve is actually being opened during the compression phase, as opposed to being occluded, as in this example below. This is an example of that happening during cardiac arrest. Ongoing CPR and compressions are obstructing the left ventricular outflow tract. This is an example of the same patient, first with compressions over the left ventricular outflow tract, and now the same patient having optimized the area of maximum compression. There's another patient with a TE showing specifically the aortic root. If you play this frame by frame, you'll see that at no point throughout this clip, there is opening of that aortic valve. So there's no forward flow. And even if you think that that doesn't make sense, you have to accept that in an image like this one, that image is now there. So how common is this problem? Well, according to prospective data from our group, this is actually a fairly common problem. Over 53% of patients had compression of the aortic root or LVOT. Another recent study from a European group showed that not only this actually occurs frequently, but that when this happens, there is, in patients that have their LVOT open, they have higher chances of survival at 24 hours. This is the first study actually linking LVOT compression and survival, and further supports the theory behind guiding resuscitation with TE. And this data has really come to confirm previous studies performed in animals, where the idea that we can generate better hemodynamics with TE guided CPR is in fact true, and that we can in fact we cannot obtain ROSC if we don't reach that target of CPP, as demonstrated back in the 90s. And another study recently showed that also, as we would expect, because it's easier to obtain TE images compared to TTE, there is a potential to also decrease the duration of pauses, further improving the effectiveness of CPR in the chest compression fraction. Last but not least, a lot of people raises the concern that using an invasive tool such as TE can distract the team or take attention away from key interventions during the resuscitation. But this video shows you how much, or how little, I should say, TE interferes with resuscitation. After obtaining the views that are needed, the probe can be literally just hung in place like this throughout the resuscitation. If you're interested in learning more of the evidence and the details, there's a great review by our group in JACC last month covering this in a more comprehensive fashion. So the take home for me is the hemodynamic-directed resuscitation not only is feasible, but could lead to better outcomes, and currently is recommended by our society guidelines. I think we can no longer accept a treatment algorithm that treats all cardiac arrest patients the same way. I think a patient-centric personal medicine approach, it is the future. But as said in this editorial, our patients need resuscitation now. Resuscitation scientists and rescuers alike should be feeling the pressure. Thank you.
Awesome. Thank you, Dr. Turan. I'm going to move on to a different lecturer right now. We are going to be talking about a completely different approach, a little bit different, more of a non-invasive resuscitation approach. We're going to hear the pros and cons, and to introduce this lecture, we're going to have Dr. Rolston. He is the Director of Critical Care and Emergency Department at Hofstra Northwell Medical Center. He is also a trauma SICU intensivist, so he's dual trained. His research focuses on improving resuscitation outcomes through evidence-based performance and bedside ultrasound use. So I think we're going to have a really interesting perspective here. And take it away, Dr. Rolston.
All right, 1 second, getting it pulled up. All right, Frosso, thank you so much for having me, and thanks everyone for listening to my talk. So, I was asked to talk about why a less invasive approach is better, but really today I want to talk about why it's faster and more effective for cardiac arrest management. So a quick disclosure, some of the research you're going to hear from today has been funded by a Zoll Foundation grant. And you just heard from Felipe Turan, who's one of the most innovative researchers and educators in resuscitation. But what he probably didn't tell you about is some of the cons of TEE and arterial lines. So first off, for a TEE, patients need to be intubated. You can't use a supraglottic device. And as we've seen in recent research that's come out in the past couple of years, especially in out-of-hospital cardiac arrest, a supraglottic device could be more beneficial than intubating a patient in cardiac arrest. I worked in a CT-ICU for 3 years, and even though I was placing TEEs pretty regularly, placement is not that easy. It can be difficult to get into the esophagus at times. So if you're not a person who's doing this frequently, and you're only doing it every 3 to 6 months, that's not going to be enough. You need to be like Felipe. You need to do deliberate practice if you want to use TEE in cardiac arrest. Now, we are using A-lines at North Shore, but we found that it takes time to set up. And placement's not easy. Seeing your needle with chest compressions ongoing is hard. Lots of our patients have vascular disease who have cardiac arrest, and it can be hard to thread a wire. And then, the reason you're putting it in is to interpret a diastolic blood pressure, as Felipe just told you. But interpreting that can be really hard in cardiac arrest, and I'm going to show you why. But the big reason these TEE and A-lines are hard in cardiac arrest is because they take time. And unfortunately, time is your enemy in cardiac arrest. So every intervention you do needs to provide the most benefit in the least amount of time. And how much time do you have? This huge study of over 280,000 bystander witness cardiac arrest out of Japan says you have about 45 minutes to get ROSC. And they really had no neurologically intact survivors after 45 minutes. At our hospital, the median time from EMS dispatch to ED arrival is 41 minutes. And 75% of all the cardiac arrests that we take care of are out of hospital cardiac arrests. That's not leaving a lot of time for TEE and A-lines to manage our cardiac arrest patients. The one caveat to this might be in ECMO patients. So in Minnesota, they're seeing pretty incredible numbers, 20% survival up to 90 minutes. But this is for a very select portion of patients who are young and generally have VF and VT arrest. So, and the thing that's really benefiting them is the ECMO. It's not the A-lines and the TEE. So what I'm telling you today, I've kind of learned from watching videos of cardiac arrest resuscitations for the past 3 years. And that's that the more interventions we do, the more complicated it is and the more time it takes. And while we all wish that our resuscitation teams looked like this, the fact is that they don't. The median time to interventions in cardiac arrest at our hospital, time to a rhythm, 2 minutes and 34 seconds. The time to first defibrillation, 5 minutes and 29 seconds. The time to intubation, 6 minutes and 8 seconds. And the time from start to finish of placing a mechanical CPR device is 70 seconds. We've even started looking at A-lines within the past year. And we're not always successful with placing an A-line. We're successful about 67% of the time. And from the time we start trying to place it to the time we finish is 5 minutes and 4 seconds. And that doesn't include setup at all. So, there's a reason why when I first did ACLS back in 2006, it looked like it did on the left. And now it looks like it does on the right. Simplicity is better in complex resuscitations like cardiac arrest. It's easier and leads to better outcomes. And the more videos I watch, the more convinced I become of the fact that unlike a golden hour in trauma, we really have to focus on those first 10 minutes in cardiac arrest care to improve outcomes for our patients. So what I'm going to try to convince you of today is that a non-invasive approach to optimize early goal-directed CPR using modalities that you use every day is more beneficial. And this starts with a better way to do pulse checks. So we can't just be using our finger on the pulse to see if we have a pulse anymore. We need to start using our ultrasound skills. And this involves placing a high-frequency linear probe over the either femoral or carotid artery and turning on the Doppler. And on the left, you can see pretty clearly there's no pulse. On the right, you can see a pulse. Just some anatomy reminders. The carotid is going to be deep and medial to the IJ. And in the femoral area, it's going to be lateral to the vein. Remember, nerve, artery, vein, empty space lymphatics as you move lateral to medial. So I'm going to show you an image of what CPR Doppler ultrasound looks like with CPR ongoing. So here we can see, as you're compressing the chest, you get bidirectional flow. There's flow moving away from the patient, away from the probe, and then there's flow moving back towards the patient. So this is causing kind of a sloshing of blood back and forth in cardiac arrest. And this leads to those problems with interpreting a diastolic blood pressure with CPR ongoing. You want to measure at point B, which is right before the chest compression. That's where you want to measure your diastolic blood pressure, but the machine is going to measure at point A automatically. So you need to know to change that cursor if you're using an A-line. Scott Weingart has a great talk on this for anyone who wants more information. So this was that same patient at the next pulse check, and the team didn't feel a pulse here, but there clearly is a pulse. Now, some people may say this is pseudo PEA. This probably isn't adequately perfusing blood pressure, but maybe this tells you, hey, we can start a norepi drip on this person. This person maybe needs more fluids. Maybe they need blood. We can try to do interventions to improve the blood pressure in this patient. And luckily, recently, there's been some research that's come out. Just 2 weeks ago in Resuscitation, a paper was published looking at the success of carotid Doppler for detecting a pulse in patients who are undergoing cardiac surgery. And as they progress to cardiac standstill with an A-line in place, the sensitivity, specificity, and accuracy of carotid Doppler were all over 90%. Even if the patient had a blood pressure that was less than 70, the sensitivity for detecting a pulse was 83%, which is much better than your finger. I need to give a shout out to one of my coworkers, Ali Cohen, whose research is looking at this exact topic, the use of Doppler ultrasound for pulse checks and cardiac arrest. She won a Young Investigator Award at the Resuscitation Science Symposium, which is happening in 2 weeks. It's a cheap conference, it's only $50. I suggest everyone attends if you have time. But what Ali's found, and she's going to present updated data on this, is that if you have a pulse, your sensitivity with Doppler ultrasound is better than manual palpation. The specificity, if you don't have a pulse, is better, and the accuracy overall of Doppler ultrasound is better than manual palpation in comparison to a gold standard of an A-line. Moving on to transthoracic echo. A couple of years ago, a group out of Highland came up with this cardiac arrest and sonographic assessment. And this has 3 components, protocol. At the first pulse check, you look for cardiac tamponade. Second one, you look for right heart strain. And the third one, you look for cardiac activity. Using this protocol, decreased compression interruptions from 19.8 seconds to 15.8 seconds. And if you put the probe on the chest before pausing your chest compressions, you were 3.1 seconds faster. At our hospital, we're using things like a countdown, 10, 9, 8, to try to limit the compression pauses. And we're also saving a clip. So hopefully you can capture all 3 components of that exam with 1 clip and review it during chest compressions before the next pause. And where is the best location to look with transthoracic echo? We've recently started looking at this as well. I was always taught that you should look at the subxiphoid area, but our success with subxiphoid is not good. 55% successful at visualization of the heart, whereas we're 92% successful with parasternal and 100% with apical. Granted, that was 2 patients. We're using a Lucas in all of our patients, so this is a little bit different. We're not using manual CPR. It can be harder with manual CPR to get parasternal view. And finally, Felipe talked about this, but the AHA recommendations from 1 week ago say that you should still do chest compressions, the lower half of the sternum. But here's an image showing a patient with the Lucas ongoing over the lower half of the sternum. And what we see is that RV is compressing really well, but that LV is not really moving. And we can see during the pause, they're still in cardiac arrest. So what we've started to do is use TTE to change the location of your CPR. We've been able to visualize this frequently, and it doesn't always require a TEE to do. So instead of doing CPR here in the lower half of your sternum, maybe you should move your CPR over to the left ventricle to get better LV compression. So in summary, team speed is critical in your cardiac arrest care. You should use Doppler ultrasound for your pulse checks. And if you're using transthoracic cardiac arrest, you should try a parasternal approach first and move compressions if you realize they're not being effective with transthoracic echo. That's my daughter, and thank you so much everyone for having me. I look forward to the discussion.
Thanks, Dr. Ralston. That was a really great talk. So we're going to move on to a 10-minute panel. If anyone has any questions or any chat points, you can put them in the chat or the Q&A and we'll try to get to them. But first, I would like to introduce Dr. Kerbedin. She is my old friend and a leader in this field. She's the medical student clerkship director and ultrasound faculty at Maimonides Medical Center. She's as well a lead collaborator on a multi-study TEE study with Sanford. She is the head at MIMO of a grant study comparing TTE versus TEE use in cardiac arrest. She also has the interesting perspective of having worked in small community settings where she's not with residents and doesn't have a million people helping her out. So she's going to have really great insight on this topic. So Dr. Kerbedin, thank you for joining us.
Hi, thank you so much for having me. And I'm honored to be here with Dr. Turan and Dr. Ralston.
So we figured for this topic for the panel, let's start off with a case and want to take everyone's approach on what the best way to manage this is. So let's say you're at a big academic center. Here in New York, you have residents, you have lots of people around, and you have an in-hospital arrest. EMS brought a patient, they don't have much information, they were kind of breathing and had an organized rhythm when they came in, and then all of a sudden they're unresponsive. You have no real information on the patient, and it looks like they're in PEA arrest. Organized rhythm on the monitor, but you don't feel a pulse. What is your best approach, Dr. Kerbedin? What do you suggest based off the information we heard from Dr. Ralston, from Dr. Turan, and based on your experience?
So I would say that age would play a large role in how I would actually address this as well. If I'm in a large academic center, like you said, I would, and it sounds like it's a witnessed cardiac arrest. This is a patient that I would assume has it's a young, healthy male, let's say, with a healthy heart, with no past medical history. Therefore, I would be pretty aggressive. I'd throw everything but the kitchen sink at this patient, hopefully if I have these resources. So I'd probably address it in a stepwise approach, knowing that my main tools here would probably be a VBG and an ultrasound. So being in a large academic center, I'm assuming I have TTE and TEE. I would then obviously secure my airway first, most importantly. Hopefully that is something that we can do in order to use the TEE, as Dr. Ralston was actually saying. I'd make sure that the patient was hooked up to Untitled, because that's a good measure of our cardiac output. Hooked on the monitor. Hopefully I have a Lucas device, place them on that to expand on my resources. Continue ACLS, have a nurse prep an A-line. Like they said, that actually takes time. So making sure that that's happening while somebody else is probably placing a FEM art line. I'd also simultaneously have somebody doing a transthoracic echo as per the CASA protocol that Dr. Ralston spoke about, looking for reversible causes. If I'm unable to obtain good views, or I'm finding that I'm increasing my time without chest compressions, I'm going to move forward to TEE. The studies out there in out-of-hospital cardiac arrest and ICUs are showing and support the use of TEE, that it has diagnostic, therapeutic, or prognostic clinical impact. To the point where it can actually aid in diagnosis in some of the studies, 78% of the time, and have therapeutic impact 67% of the time. So first off, in the TEE, what I would be doing is, especially in this patient, looking for signs of obstruction, starting with cardiac tamponade. I just want to stop for 1 second. Did you say that the patient had no pulse?
You can't feel a pulse.
So, like I said, I would start looking for signs of obstruction, starting with cardiac tamponade. Why cardiac tamponade? Because it's the cause of PA arrest in about 4 to 15% of cases. And actually identifying tamponade will significantly affect the chance of survival of the hospital discharge. It can actually be, which is around like 15%, much higher than the other causes of PA arrest. Next, I look for signs of right heart strain, which is a little bit of a tricky thing. So maybe possibly also add in DVT ultrasounds bilaterally, further to like solidify my clinical suspicion of a PE in order to consider using thrombolytics. Next, cardiac wall motion abnormalities like wall, valve ruptures, thrombi, pseudo-PEA, which would be really important and change my management, hypovolemia, and do a lung sweep to look for pneumothoraces. Basically, I'd be looking for all of the reversible causes that we can address to increase the chance of ROSC. Next, what about Dr. Tehran was talking about is that TE has actually become instrumental in guiding chest compressions. His study citing that 53% of the time, we're over the LVOT and aortic root. So there's also one of the first studies that came out a while ago showed that we're only over the LV 20% of the time. So hopefully by optimizing positioning, we can lead to better hemodynamic parameters, and that may lead to better outcomes. I'd use that along with the diastolic blood pressure, hopefully if I'm using it correctly. Lastly, like they were talking about, if this large academic center had ECMO, there's very few hospitals have ED ECMO. I would consider that. We can use the TEE to help with cannulation, and we can initiate ECMO, hopefully to bridge these patients to reversible causes, such as like the cath lab.
Sounds like a good combined approach. I want to, before I kind of hear from Dr. Rolston and Dr. Tehran, what do you guys suggest for people who, number one, don't have a TEE? And number two, let's say they have ultrasound, but they're saying, look, I can't do ultrasound guided CPR. It's hard to find a window. I'm not ultrasound trained like all of you are. So what would be your kind of advice for someone who doesn't have all the fancy equipment and maybe isn't as comfortable with ultrasound?
So, I can lead off with this one, but, if you're not comfortable using ultrasound, I think that's okay. That's part of being an ER doctor. But, you can use end-tidal CO2, as Felipe mentioned, to try to guide your resuscitation to see how effective your chest compressions are. As we've mentioned here, I think eventually we're going to be moving that chest compression location from the lower sternum over to the left. So if you find you're not getting ROSC, try moving your chest compression location just empirically. I think just practicing good care, getting a good early rhythm recognition, finding out if you're in VF and this patient needs to be shocked is one of the most important things that we do. And it's one of the things that we find the biggest delays to when we look at these videos. So I think just focusing on some of the basics is still really important to taking good care of these patients.
And to kind of go off of that question, let's say you're at a community hospital. You don't have residents. You don't have a lot of people and you don't have a Lucas device. How do you go forward in optimizing your resuscitation? What would be like the most important steps first to do, let's say, if you're only one person doing these more advanced procedures?
I can take the lead on this one, but I'm gonna actually just add a piece of my answer to the previous question. And I'm just going to say that if you feel uncomfortable with ultrasound and you're an ER doctor and you're running resuscitations, then we have a problem, and you should probably not be running resuscitations and perhaps not be a doctor. And so I think that should be the north. That person should get appropriately trained, because to me, it's like being an ER doctor and not being able to intubate in 2020. And there's lots of questions in the chat regarding what to do if you don't have TE. And I just want to reply kind of generally saying that the situation of not having TE is at this point the most common situation across the board. And so what people should do if they don't have TE is to use what they have, and what they have is hopefully TTE. I have a different opinion regarding actually the role and the ability of TTE to guide the area of compression and the location in resuscitation. And that is because, as we've seen in many clips, the images that we generate with TTE, because of the angle in which we're generating those images, are not actually representative of that interposterior plane in which we're compressing the heart. So very often, I think I see people interpret it, and what I think is misinterpret the images from TTE when they see that the image intermittently goes in and out of view, essentially, and they interpret that as lack of compression. And I think what's happening is simply that the image is not an informative image of that shortening in the interposterior plane. To your question of community hospital, I haven't practiced in a setting like the one that you're describing. And so I'm going to start by disclosing that I don't have personal experience of practicing in an environment where I don't have the support that I have right now of multiple providers, often too many providers to run a resuscitation. But I would say that just intuitively, what I think I would do in that case is to stick to the basics and the fundamentals. And the fundamentals involve recognizing arrest. So whether it's with Doppler, whether it's with an A-line, whatever you have, you need to be able to be as certain as possible that the patient has a pulse or the patient does not have a pulse, and to identify when the patient returns to spontaneous circulation. I think ultrasound and TTE or TE should also be part of standard care in community hospitals. I don't see why we need to restrict that. And so it is my expectation that community hospitals and non-academic practices should have and should be using ultrasound and echocardiography to run the resuscitations as well.
So I just want to, Tom Pereira is yelling at me on the chat, so I need to respond. I honestly think, obviously I just gave an entire talk about ultrasound. I think it's important for people to know how to use an ultrasound, but, the truth is the evidence has never shown improvement in neurologically intact survival with the use of ultrasound and cardiac arrest. Now, hopefully Felipe and I and Ali Cohen and Jeanette will, finally show an improvement, but that has not been proven so far. So I don't think you can say to a community doc that it's, you have to be, you're doing the wrong thing if you don't have ultrasound. It's not proven yet.
I do agree that I wanted to echo what Felipe said. Like, I do think that most of these hospitals should have an ultrasound, right? Most residents graduate where they are able to perform ultrasound, they're credentialed in ultrasound. I did work at a community setting, and we were lucky and fortunate enough to have an ultrasound, but we didn't have much else. I was the only doctor. I had limited nurses. And so really my main goal was kind of, how can I use this ultrasound and like a VBG to figure out what's going on with these patients and really to stabilize that patient. Like, we weren't a STEMI center. So if it was a STEMI, my thought was, how do I stabilize this patient? Maybe give them thrombolytics and transfer them. So that would really be my main thing, like give them the standard of care, giving, ACLS, and I'd be using like Untitled CO2, non-invasive blood pressure cuff, because things like you guys are talking about, like an A-line, is kind of like out of the question at a community setting where you're kind of the only doctor and a nurse is going to be standing there prepping an A-line for a prolonged period of time. And who's going to be putting it in? Somebody has to secure the airway, then throw the ultrasound on. So honestly, there are some studies out there, especially in like the septic patients and ICUs, that show that non-invasive blood pressure cuff with probably Untitled CO2 will suffice. And I'm happy with that. So I'd use those tools and just standard ACLS protocol and stabilize the patient and transfer to somewhere that may be able to manage them properly.
Awesome. That was a great discussion, guys. Thank you. That's all the time we have for the panel. I think those were two great talks and a really great panel discussion talking about the different ways that we can do better at resuscitating our patients.